So in this unit, we do ED critical care, which means we take care of the patient at a level beyond what a standard ED could do. And you are the primary provider of that care. So we don't say, oh, we'll leave that to the team upstairs, we do it down here. We maximally resuscitate a patient before we're willing to send them upstairs. First key thing to remember is you gotta always be thinking bed management. You'll have to be thinking about flow and moving patients out of here to make room for the next set, which means you'll always try to keep one bed open. If you have a patient that's not too sick and the room is full, all 4 beds are filled up, you send a patient out. Now, oftentimes the nurses will want to send a patient out who's still sick and you have less than 4 patients. Don't. Hold on to that patient. We keep them until they're not sick anymore, and then we send them out unless we're forced to. And if that means keeping all 4 beds full, that's fine. Sometimes the patients will overflow into trauma. That's still part of this unit, and those are still your patients. So you might be caring for 7 patients sometimes. That has been known to happen. When a new patient comes in, no matter what else you're doing, you go and you see that patient. You see them at their bedside, you speak to them for a few minutes, you make sure they're stable enough for you to finish up whatever else you're doing. You don't check out their chart on the computer, you don't play around with the papers that came with them, you go and see the patient. After you do that, then you can do whatever else you need to do. So when a new patient arrives, I expect you to go see the patient instantly. Try to keep the place clean, try to keep your work area tidy. You're not going to perform well otherwise. There's no eating in this room. If you have a clear liquid and you want to drink, it's fine. For me, the nurse administrators might say different, but it's bad form to have uncovered coffee and stuff like that, because inevitably it's going to spill and get everything really mucked up. Now that you're in here, your job's not to start IVs or draw labs. Your job is to take care of the patient. If folks can't get an IV and they come to you and say you need to do it, that's fine. But see, oftentimes the second years they come in here and since they don't know necessarily what else to do for the patient, they start playing around, starting IVs and drawing labs. It's not a good use of your time. All right, if you have a sick patient, you go with them to CT scan or whatever imaging you need. You put them on a ProPack and you take them over. Otherwise, they get taken by transport. They get put in the waiting room at CT. They wait there for an hour, 2 hours, and they can decompensate while they're over there. So if they're sick, you go with them. If it gets too busy in here, you ask for help. First, you talk to your attending. You tell them, look, I'm getting overwhelmed here. What do you think I should do? And they'll prioritize for you. But there's always a ton of extra residents outside. And if you have 4 sick patients come in simultaneously, you take care of 1 or 2 of them, and you call one of your friends in from outside to take care of the other 2. All right? Because the one thing we have here at Elmhurst is we have a prioritization of the sick patients, and we have more than enough manpower to make that happen. If it means that non-sick patients have to wait a bit, that's okay. So you can't just let the patients, if they're not complaining, and you can't pretend everything's okay. You have to, I do it every 15 minutes or so. I just round on all the patients in the unit and make sure that they haven't decompensated, that nothing changed. Because what will happen is their BP will read 60/40, but no one's checking on that. And it behooves you to make sure that that doesn't go on for more than a couple minutes without recognizing it. What else? In terms of procedures, for the entirety of your second year, you don't do anything of any great severity without checking with your attending first, which means you check with them before you do a central line on your own, you check with them before you do an LP on your own, you check with them before you pretty much do any procedure more than an IV or an NG tube on your own. And if they tell you, I think you're okay, go for it, then that's fine. But until they say it, check with them first. So all our procedures in here are done full sterile, and that means central lines, arterial lines, lumbar punctures, whatever it is, we never ever put in non-sterile lines. It's just not done. Now if you're in the cardiac arrest, I don't see any reason to start a central line, so even that's not an excuse. But if for some reason you are, then that line gets changed out while the patient's down here. A patient will never leave this unit with a non-sterile line.